برضه منى يعني على الرغم مشغولياتها وكانت عندها لجنه ترقيات امبارح كتر خيرها لجنه هندسه مساعدين ويعني شرفتنا ونورتنا. ثانك يو فيري ماتش. يعني التكريم ده اقل من قيمتكم عندنا كتير عن كده. ونشكر يعني جنزايم يعني سانوفي جنزايم مره اخرى وجمجوم برضه اللي كانوا عاملين السبونسر شيب للميتنج اللي قبل كده. متشكرين دكتور سيد كتر خيرك، جاي بقى انت من دمياط مخصوص عشان تنورنا. الله يكرمك، اهلا وسهلا بيك. دكتور محسن اتفضل.
اتفضل يا حبيبي. كل سنة يا دكتور مرتضى ودكتور طلال الواحد بيقول معقولة السنة الجاية المؤتمر هيتعمل ويبقى قوي كده أو أقوى. السنة دي بتثبتوا كل سنة إنه المؤتمر أقوى سنة بعد سنة. أنت فصيح يا دكتور مرتضى وصاحب فكر. دي الجلسة ال14 في المؤتمر ال29 لأمراض الكبد والجهاز الهضمي والتغذية، ويسعدني ويشرفني يكون معايا كوتشير أحمد بكار وأحمد محمود and myself. وعندنا two important speakers، الأستاذة الدكتورة ماجي عبد الوهاب. الأستاذة الدكتورة ماجي أستاذ طب الأطفال وأمراض الدم في القصر العيني أبو الريش، واتكلمنا على very important topic. الحقيقة لما ابتديت رحلة الجوشين مع الدكتور سامي خليفة من 25 سنة، ثم الدكتورة عزة دخلت، ثم إيمان منير، ثم أميرة في عين شمس، وفي المقابل الدكتورة أمال المشلاوي وماجي، وفي الزقازيق أسامة وتامر والمجموعة كلها. وابتدى يبقى موجود أويرنس في البلد كلها. الجوشين مرة كان incurable بإنزيم ريبليسمنت، بقى مرض لما يتشخص بدري الكيور 100%. نيمان بيك ان شاء الله يبقى نفس الحكايه. الاستاذه الدكتوره ماجي هتكلمنا على جوشيه ديزيز. زي ما انا بقول اذا treatable disease is hepatic involvement is reversible. رايكم ايه؟ هل الهيباتيك is reversible ولا نسمع الاجابه من الدكتوره ماجي؟ اتفضلي يا دكتوره ماجي.
Thank you. Thank you so much, Professor Mohsen Al-Alfi, for the very kind introduction. And I would like to thank Dr. Murtada and Dr. Talal for the kind invitation to share the experience of our unique Gaucher disease cohort. Now, this is our Cairo University Pediatric Hospital, for those who don't know it. And this is one, actually, it used to be one of 3 hospitals. Now it's one of 4 hospitals. And this is where the hematology outpatient clinic is based, where our Gaucher disease patients take their treatment. But a significant cohort now are receiving home therapy. So I'll be talking a bit about the historical background of Gaucher disease, the pathophysiology, types and prevalence, etiology, phenotype, genotype correlation, clinical presentation, highlighting that of our Egyptian cohort, whether the GD1 or the GD3, hepatic involvement, case study, diagnosis, treatment, highlighting therapeutic goals, monitoring, response of hepatic involvement to ERT. ممكن احنا بس نماجنيفاي شويه. Okay, so as you see here that Gaucher disease has started to be known by a PhD thesis of Philippe Gaucher, who thought it to be a neoplasm of the spleen. However, around 150 years later, we now know a lot about Gaucher, yet there are so many unmet needs. And actually the discovery of the underlying biochemical defect by Brady, who is one of the leads in the lysosomal storage disorders, has really made a great significance. And then afterwards, the ultimate discovery of the enzyme therapy in 1996. So, regarding the pathophysiology of Gaucher disease, as you can see, the monocytes will mature to macrophages in the marrow of specific sites, like the liver Kupffer cells, the osteoclasts, and the lung and tissue macrophages. Mutations in the GBA gene will lead to a markedly decreased activity of the lysosomal enzyme glucocerebrosidase. Actually, the glucocerebrosidase, as you can see here, what it does is that it hydrolyzes the glucosyl ceramide into ceramide and glucose. So when it is deficient, and in the presence of the macrophages, it accumulates the glucosyl ceramide. And it leads to the unique end-stage Gaucher cells with its eccentric nucleus pushed to the side and the crumpled paper appearance. Now, very interestingly, we conducted a study with the inborn errors of metabolism unit to see the prevalence of Gaucher disease in our community, and it constituted 48% of the sphingolipidosis in Egypt. It comes second after the MPS. Classically, and here I would like to really highlight classically, Gaucher disease has 3 phenotypes depending on the absence, the presence, and the severity of neurological signs. The type 1, the non-neuronopathic, very well known, and then the NGD, which was discovered later, the type 2 and 3. However, I would like really to emphasize that Gaucher disease is a continuum of phenotype, and that demarcation is quite imprecise. Very interestingly, the prevalence of Gaucher in the general population is around 1 to 50,000, but very, very high in the Ashkenazi Jewish population, but around 97% is the type 1. Regarding the neuropathic, it's quite rare, less than 1 per 100 live birth, with type 3 the most prevalent, constituting 5%, and the type 2 only 1%. However, it's very important to note that it's quite high, the type 3 I mean, in the Eastern population, whether the Far Eastern population, Japan, China, or the Middle East, showing highest prevalence in Egypt, sometimes mounting to more than 70%. So, regarding the underlying gene, it is unique for Gaucher disease, with more than 400 mutations. The commonest linked to type 1 is the N370S, and that is the commonest in the Ashkenazi Jewish population. The L4P, of course, this is the old nomenclature that most people are used to, still remains the most frequently encountered disease-causing allele, reported to predict a high likelihood of NGD. However, and I would like here to stress again, there's significant unexplained variability in the phenotypic spectrum of patients homozygous for L4P, and that's probably due to genetic modifier genes, and we're conducting a study now on that. Regarding the phenotype-genotype correlation, the homozygous D409 shows some genotype-phenotype correlation. You would find calcification in the cardiac valves and in the aorta, together with corneal opacities and sometimes hydrocephalic changes. However, because our cohort is unique, even in the homozygous L4P, we noted these calcifications. Now, clinical manifestations of the GD1 are quite variable than the NGD. However, in the GD1, the symptoms can begin at any age, but 2/3 in childhood, and more than 50% are diagnosed by the age of 10 years. Now here, I wrote hepatosplenomegaly, but I would like here to say splenohepatomegaly, because it's unlike other lysosomal storage disorders. The spleen is usually the most affected in more than 95% of children. Anemia is noted in 50%. The patients can also have thrombocytopenia, but it's not a constant variant, a constant finding. Bony manifestations mount up to 80%, including the bony aches, the Erlenmeyer flask deformity that is only noted on X-ray, and pathological fractures, as well as osteopenia. Growth delay in about 50%, there will be growth delay, and 25% will be less than the 5th centile. It could be associated with pubertal delay, fatigue, and fatigue is very important in type 1. because it impairs school performance. Now, at the end, I will just say Gaucheromas, and I will leave it to the slides afterwards to explain what that is, because actually, though thought to be rare, it can be the initial presenting symptom. Regarding the GD3 or the Gaucher disease type 3, I will classify the manifestations into neurological and non-neurological. Patients can present with psychomotor delay, and supranuclear gaze palsy that's highlighted in yellow is very important and pathognomonic for the diagnosis of NGD, and specifically type 3. Squint was noted in 22% of our cohort. Bulbar symptoms, whether dysphagia, dysarthria, were noted in 37%. Cognitive impairment is quite variable. Seizures quite high in our cohort, that's why highlighted in white, as well as behavioral problems noted for the first time in our cohort. And actually, it was quite a struggle with the West to let them believe that behavioral abnormalities is not a comorbidity, and patients were diagnosed as having ADHD together with Gaucher disease, but actually it's part of the disease spectrum, and it was discovered later in the knockout mouse. And then unique to our cohort is the sudden unexplained death of epilepsy phenomena. Regarding the non-neurological, there's the hepatosplenomegaly, bicytopenia, bone, lung, kyphoscoliosis, and then the lymphadenopathy, eye, and dental and cardiac manifestations. Okay, this is the neurological symptoms in more details. For those who are interested, I will just highlight the first item. Patients can present with type 3 as early as during the first 6 months of life and as late as adulthood. However, the majority present in childhood, 47 before 2 years of age. Okay, regarding the non-neurological, I will focus today on the hepatosplenomegaly and specifically on the hepatomegaly, together with the liver cirrhosis and Gaucheromas. Now, what you see here is the spectrum of Gaucher disease. Sorry if it's not that clear. At one end, you will see here the type 1, which can be asymptomatic. At another end, you will see severe form of GD that can present in the neonatal period with ichthyosis or hydrops fetalis. So this is the very famous diagram showing that GD is a continuum of phenotype by Ellen Sidrensky. By the way, she is very important because she is the first one who linked the GBA gene to Parkinson's disease. Okay, this figure actually is my perspective of a continuum of phenotype. You will see here that the GD1 and the GD3 have hepatosplenomegaly, bicytopenia, bone growth delay, eye, lung, and Gaucheromas. Whereas the GD2 and the GD3 will share these manifestations, whether the cognitive abnormalities, the seizures, the squint, the bulbar, or the lung manifestations. Okay, liver involvement in Gaucher disease. Evaluating and managing liver disease in patients with Gaucher can be challenging. Gaucher disease, and that's very important, can mimic hepatic lesions, affect laboratory tests used to characterize liver disease, which complicates the diagnostic approach even more. So again, like Dr. Mona said, we have to think Gaucher, and especially if it's initially presenting with hepatic involvement, as we are going to see later in one of our cases. The severity and clinical significance of hepatic involvement span a wide spectrum, ranging from subclinical involvement to liver cirrhosis, with its associated complications, including portal hypertension and impaired coagulation profile. Very interestingly, we noted in our GD3 cohort a prevalence of 10% of liver cirrhosis, which is very, very minimally reported worldwide. In the liver, several patterns of Gaucher cell infiltration have been reported, including scattered foci, prominent centrilobular infiltration, and extensive replacement of the liver parenchyma with Gaucher cells. Diagnosis. A diagnosis of Gaucher disease is based on clinical signs and symptoms, family history, and confirmed by laboratory testing and genetic testing. Please, again, bone marrow aspirate and biopsy is totally non-specific. Neither confirms nor excludes. Once a diagnosis is suspected, beta-glucose reversibilase activity in total leukocytes or mononuclear cells or cultured fibroblasts is measured. The low enzymatic activity is the gold standard for the diagnosis of Gaucher disease. However, you will have a residual of the enzyme activity. Regarding the genotype, we usually do sequencing for common mutations. The diagnosis of type 3 is based on genotype and/or neurological abnormalities. So what's important here is the neurological abnormalities, not the genotype. Let's say we have a patient with homozygous L44P, the commonest gene mutation associated with type 3, and the patient does not have supranuclear gaze palsy. Is this patient type 3? No, until he starts having the supranuclear gaze palsy. Family screening is also very important to start therapy, as Professor Alfie said, very early, even before manifesting. So a case review. That case actually we managed together with Hematology. A 14-year-old boy of a consanguineous marriage presented at the age of 7 days with jaundice and hepatosplenomegaly. Then developed umbilical bleeding, received plasma and vitamin K. He was diagnosed as having cholestasis at the age of 26 days. At the age of 2 months, the patient's hepatic condition was diagnosed as progressive familial intrahepatic cholestasis. At the age of 3 months, the patient developed cytopenia, and bone marrow aspirant was done repeatedly, showing no abnormality. At the age of 3 years, the patient developed liver cirrhosis and varices, which was injected 8 times. At the age of 5 years, he started to have mild to moderate epistaxis due to impaired coagulation profile. Okay, what happened afterwards? His younger 2-year-old sister developed supranuclear gaze palsy and bulbar symptoms, together with recurrent chest infections, as well as organomegaly and anemia. She was investigated and found to be a Gaucher disease patient. Her brother was investigated again. Both showed low beta-glucose reversibilase as well as a high serum chitotriosidase. Liver cirrhosis secondary to Gaucher, complicated with portal hypertension and an impaired coagulation profile, can be an initial presenting symptom and can present very early. But actually, that's quite rare. But our cohort is unique. So, regarding treatment, the first question we are encountered with: who to treat? Treatment, very expensive, lifelong, bi-weekly, should be given to all children with GD1 and all those with confirmed GD3, whether they are neurologically asymptomatic, diagnosed by genotype, sibling of a confirmed type 3 patient, or symptomatic, and fulfilling the criteria with no contraindication to regular bi-weekly IV infusion. Second important issue is the multidisciplinary approach in those patients. ERT, or enzyme replacement therapy, is the gold standard of treatment. Now, this figure sums up the treatment in a nutshell. So it can be ERT, SRT, substrate reduction therapy, or pharmacological chaperones. Enzyme replacement therapy, the first discovered, as we saw in the historical background slide, was the amiglucerase. It was FDA approved in 1994. It has marked beneficial effects on visceral and hematological diseases in type 1 and type 3, but its effect on existing neurological signs and their progression is a subject of great debate, and that's really important. There are some reports of stabilization of neurological manifestations, such as the nuclear gaze palsy and cognitive function, and improvement of other symptoms. In our cohort, we noted improvement of the bulbar symptoms and the behavioral symptoms. How? When the drug does not cross the blood-brain barrier. Well, it's something I leave it for you to think about. I think I have a hypothesis there. Regarding the other enzyme replacement therapies, there is the viluglucerase alpha, which was FDA approved in 2010. Now, something actually very unpleasant happened. During the period of 2009 to 2011, we call it the enzyme shortage period. There was a problem with the plant. Okay, so amiglucerase was not produced, and at the time, viluglucerase alpha was there, and it was FDA approved. There's another ERT, and that's the teliglucerase alpha, which was approved in 2012. ERT treatment guidelines in children and adolescents. Approved dose is 60 IU per kg biweekly in both types, but individualized dosing applies, and by that I mean, for example, in some patients, we can give it weekly. Okay, regarding type 1 patients, if they are more than 18 or more than 16 and post-pubertal, this is very important. They have evidence of severe disease, then the starting dose is 30 to 60 IU. If they have non-severe, then it's 30 IU. But patients have to be reviewed after 6 to 12 months to adjust dose according to treatment outcomes. Substrate reduction therapy are oral, and this is very important, FDA-approved drugs. They reduce the glucose hydroxide formation in very simple terms. There's the miglustat, okay, that is used for Niemann-Pick, and the eliglustat, the Serdelga. It inhibits the glucosyl ceramide synthetase, catalyzing the biosynthesis of the glycosphingolipids, and so it reduces the load of the glucosyl ceramide into the lysosomes. It's not indicated for type 3 except for compassionate use. The newest drug by Sanofi is the venglustat. It can be combined with ERT, usually the amiglucerase. It has the privilege of penetrating the brain. Currently, it's phase 3 clinical trials. And then there are the pharmacological chaperones. Now, these are very important. Amproxil, this is a very cheap drug. And I don't remember which one of the talks yesterday who was pointing to the Japanese and how they were leading things. Okay, Amproxil, it's an on-shelf drug, and that was first used by the Japanese because they had severe type 3 Gaucher disease with significant seizures that is not responsive to treatment. Actually, these chaperones, they increase the residual protein function by stabilizing the misfolded mutant proteins. And they're able to cross the blood-brain barrier. BMT, well, there have been earlier studies of BMT, but the problem with BMT is that it only reverses the hematological and the visceral, and then there are the pros and cons of the BMT. So actually, it's no longer used in most places. Okay, systematic, supportive, and adjunctive management options. These are very, very important, especially in countries with a resource constraint where the enzyme is not available. Splenectomy, please, it's contraindicated in all type 3 patients. What it does is that you remove the spleen, so the disease burden increases elsewhere. And so it worsens the neurological and the bony manifestations in those patients. Of course, usually, but there are no always in everything. Also, we can give blood transfusion and iron supplements when the hemoglobin drops, until, of course, the ERT is started. Then there are the disease complications. I won't go through all that. I will just highlight hepatic here. In cases of cirrhosis, portal hypertension and varices are treated with injection sclerotherapy, as we usually do, and these patients are maintained on beta blockers, and they are doing good. And the coagulation profile does not always have to be corrected, as we are going to see later in the other presentation. Genetic counseling is very important. Gene therapy, well, now that's the magic in everything. Gaucher disease is a good example for this, and hopefully it will be in the market soon. And there are trials ongoing. Okay. If we are treating patients, we have to monitor patients. There's the clinical assessment, and there's the severity scoring tool. There's the severity scoring index by Zimran et al. Dr. Ari Zimran is one of the leads, if not the lead, in this field for type 1. Okay? There is also the neurological severity scoring tool for the type 3. But it both needs to be revisited in view of the current changing manifestations of Gaucher disease and the very wide phenotypic spectrum, because patients are living much, much longer, and we are seeing a new phenotype of the disease. Laboratory assessment, there is the hematological parameters and liver function tests, even if and when indicated, then the radiological abdominal ultrasound to assess the liver and spleen volumes. And this is very interestingly calculated as multiple of normal, predicted for body weight. For example, mild or normal hepatomegaly is less than or equal to 1.25 multiple of normals, moderate more than 1.25 to 2.5, severe more than 2.5 multiple of normals. CT abdomen is important. In our cohort, we noted about 30% prevalence of lymphadenopathy, so it's important. It's due to the infiltration of Gaucher cells to the lymph nodes. This is the other routine things done. Biomarkers, very important, the lyso-GB1. It reflects disease burden and monitors the treatment response. It used to be serum chitotriosidase and others, but now it's the lyso-GB1. Problem with serum chito is in 4% of the of the European population, they have a mutation for the chitotriosidase enzyme. Therapeutic goals, I'm going here just to highlight that for the liver, the rest is whoever is interested for the sake of time. Therapeutic goals for hepatomegaly is to reduce liver volume to 1 to 1.5 times normal. It should decrease by 20 to 30% within a year to 2 years, and by 30 to 40% by year 3 to 5. Volume normalization is generally not possible when hepatomegaly is severe, presumably due to presence of fibrosis. Regarding our cohort, in the past 15 years or more, the hepatomegaly has regressed significantly when we measure it with multiple of normals as well as the splenomegaly. And again, like I pointed in the previous slides, the liver volume is higher in patients with more severe and GD and in splenectomized patients. And usually the liver volume, when huge, it will not regress to normal. Therapy for GD, both ERT and substrate reduction therapy is effective in reducing or normalizing liver volume. However, hepatomegaly may persist despite treatment when severe, nodular, significant liver fibrosis or splenectomy is present. And actually we have that noted in some of our patients. Okay, Gaucheromas. In all the publications you will see that one of the places the ERT cannot reach is the Gaucheromas. But in our cohort, this is a patient with severe type 3 who has so many manifestations, including seizures. This is his initial CT. And here you would see a pelvic abdominal mass, and here you would see the lymphadenopathy together with the calcification. Here you can see, sorry, it's a bit blurred, it's not that all that clear, but I think you can see that there is a regression of the pelvic abdominal mass as well as the lymphadenopathy. So ERT can reach these places, but it took it 7 years, and it does the same for the lung. So it's a matter of duration, and of course, it's a relatively partial regression. Now, take-home messages. Splenomegaly and thrombocytopenia are the dominant clinical features in many GD patients, leading to first medical contact. The hepatologist and the gastroenterologist need to be aware of this condition. Currently, we have 7 treating centers for Gaucher disease. One of them, of course, is in Mansoura. And in Mansoura, okay. And in Mansoura, it's the hepatology clinic who are managing the Gaucher disease patients. Enzyme, okay, there are here 3 gold standards. Enzyme assay is the gold standard of diagnosis. Supranuclear Gauss palsy is the gold standard of neuronopathic GD diagnosis. ERT is the gold standard of therapy, used in all types of GD. Visceral, hematological, and growth parameters can be reversible, but other manifestations, like the neurological, the lung, the lymphadenopathy, they require other therapies, and that's where the gene therapy role comes. Multidisciplinary approach is mandatory in managing those patients and is now becoming the standard of care. There are many unmet needs now, and that's why currently the guidelines for treatment of Gaucher disease are revisited and they are rewritten, but with a different perspective. It's called patient-centric perspective. It's not just the physician's perspective. There is used to be the European Working Group for Gaucher disease. Now it's the International Working Group for Gaucher disease, as well as the International Gaucher Alliance, and that's the biggest patient group worldwide. You could say even worldwide for the lysosomal storage, but it's for Gaucher disease, and it's based in the UK. So both, they got together and they are writing patient-centric guidelines. For example, there is patient-reported outcomes. These need to be included. The patient's perspective needs to be included. You are treating the patient, and then, okay. The patient does not have splenomegaly, but the patient has fatigue. So you have to listen from the patient. Okay. ممكن أقول هيبوكرات قال إيه؟ زي دكتور مرتضى. Okay. In medicine, one must pay attention not to plausible theorizing, yani theories, but to experience and reason together. I agree that theorizing is to be approved, provided that it's based on facts. وزي ما حضرتك قلت, facts can change. Facts, what we see through experience. And systematically, it makes its deductions from what is observed. But conclusions, وده بيحصل مع الأسف دلوقتي كتير في المedicine, drawn from unaided reason, can hardly be servable. Only those drawn from the observed facts. That's our national and that's our international group. Thank you very much.
Thank you, Professor Magy. Thank you, Professor Magy, for wonderful lecture.
Thank you.
Actually, we will not open for discussion, but I'll give last comment. Gaucher مجمع الجامعات مع بعض وسانوفي supporting الجوشيه patient. هنا تايب 1 ميكسد مع عينين الثلاسيميا والسيكل سيل انيميا والعينين بتوع الفراكشرز والريكس والحاجات دي. تايب 1 و 2 هو اللي difficult to diagnose مع عينين النيورولوجي والميتابوليك وكده علشان صعوبة البلع والتنفس والحاجات دي. تايب 2 و 3 1 و 2 محتاجين واحد حريف. تايب 1 محتاج بس awareness وناخد بالنا من السبلينوميجالي. مش هيبقى هيوش في الاول، عند سن سنتين ولا سنه هيبقى صغير وخمس. بهاء حسنين ونسمع بقى ونستمتع.